Okay, let's go ahead and get started. I see some people are still joining, but they can join us as they're able. My name is Jessica Farringer. I'm the Acting Director of Data for Impact, and welcome to our webinar. Just a few words about our work. Data for Impact works with country partners to strengthen capacity to generate and use high quality health and other development sector data, use routine and other existing data, and investigate program effectiveness and support adaptive management with evidence. Today's webinar is the second in our D4I series focused on integration in global health. We have presentations today on two recent DHS studies that integrated data, specifically household survey and health facility assessment data, and geospatial covariate and household survey data. Our February webinar addressed measurement of gender competency for gender integrated family planning programs, and you can find that recording on our D4I website. Our next webinar in the series will be on April 19th, and we'll explore the integration of machine learning models with electronic medical records as achieved through the Kenya Health Management Information System, or KEHMIS project. And then in May, we have a webinar that was rescheduled from January on integration of zoonotic and human health data through the One Health system in Burkina Faso. Our June webinar topic is being determined and will be announced soon. So now I'd like to introduce today's two presenters. First, we have Rose Donohue. She is a senior geospatial data scientist with ICF International working on the DHS program. She has a PhD in biological sciences and an MS in global health from the University of Notre Dame. And we then have Dr. Sara Riese, who's a senior demographic and health researcher at the DHS program, focusing on quality of care, maternal and child health services, family planning, and inequality. She holds a master's degree in international affairs and public health from Columbia University and a PhD in population, family, and reproductive health from Johns Hopkins University. We are going to hold questions for both of these presentations until the end. There will be time for questions and discussion. If you have questions as we go along, however, please feel free to put those in the Q&A. Please do not put questions in the chat, but we would like you, however, if you have not done so already, to introduce yourself with your name, organization, and location in the chat. And with that, I will pass things over to Dr. Donohue. Rose?
Great, thank you. Okay, so thank you for all attending today. So today I'll be presenting on integrating geospatial covariate and DHS survey data to model DHS indicators at the second subnational administrative level. So this work was done in collaboration with Ben Mayala, who has led the geospatial modeling efforts at DHS for the past 4 years. To give you a brief background, the DHS program is funded by the United States Agency for International Development to provide technical assistance in the collection and use of data. The DHS program provides nationally representative data to monitor and evaluate population, health, and nutrition programs. The DHS program is most widely known for the demographic and health surveys. These are nationally representative household surveys that have large sample sizes. So usually between 5,000 and 30,000 households are surveyed for a country. They collect data on a range of health and demographic topics, including fertility, mortality, family planning, maternal and child health, nutrition, and HIV/AIDS. These surveys are typically collected about every 5 years in a country. So in the map on the bottom, we see all of the countries that are shaded in green have had a DHS survey. The countries in lighter green have had fewer, while the countries in darker green have had more. But as you can see, DHS surveys have been conducted in a large number of countries with a wide geographical distribution. So the title of this presentation refers to estimating DHS indicators at the second subnational administrative level. So I want to briefly describe the terminology we'll be using. To start with, country borders themselves are referred to as Administrative Level 0, or Admin 0. The largest administrative divisions within a country are referred to as the first administrative level, or Admin 1. While Admin 1 names can vary by country, they are frequently referred to as provinces or regions. The second largest administrative divisions within a country are referred to as the second administrative level, or Admin 2. So again, while these names vary by country, they are frequently referred to as districts or municipalities. DHS indicators are estimated nationally at Admin 0 and are generally estimated subnationally at the Admin 1 level. The national level estimates are useful for comparing nations and aggregating across large world regions, and here the audience is generally international policymakers and donors. The Admin 1 estimates are useful for comparing regions within a country and evaluating regional differences. So while DHS surveys generally provide estimates at Admin 0 and Admin 1, they are not generally designed to provide estimates at the Admin 2 level. Therefore, the only information we have about an Admin 2 is the average of the Admin 1 in which the Admin 2 is located. However, we know that averages can hide important local health variation. This can be seen on a larger scale when comparing the Admin 0 and Admin 1 maps. You can see that variation exists within countries, such as the higher prevalence here in Kigali, and that isn't apparent when reviewing the national estimate alone. So given that health programs are often designed and implemented at the Admin 2 level, we've identified the lack of comprehensive Admin 2 estimates as a gap we would like to address. Given that we'd like to regularly produce indicator estimates at the Admin 2 level, we need to review and evaluate the different approaches that exist to accomplish this task. One approach would be to increase the survey sample size. A second would be to use data from routine health management information systems, or HMIS. And a third would be to use a statistical approach, such as small area estimation. The issue with increasing survey sample size is that it is expensive. As I showed in a previous slide, the DHS surveys already have a very large sample size, so we don't find this approach would be particularly feasible in an increasingly resource-constrained environment. The issue with using HMIS data is that the data quality isn't always reliable, data is not easily accessible, data is also not available for all indicators that DHS collects, and there's inconsistencies across areas, both within and between countries. Therefore, we've opted for the third approach, and here we're specifically talking about geospatial modeling. This approach is more affordable than increasing the survey sample size, and the data is more reliable, accessible, available, and consistent than HMIS data. Geospatial modeling is widely recognized as an excellent technique to conduct small area estimation. It leverages existing survey data, the spatial relationships between survey clusters, and the relationships with geospatial covariates. Geospatial covariates are environmental and socioeconomic data layers that are correlated with the indicator of interest. Geospatial modeling uses this data to help estimate a relationship between the covariates and the indicator of interest, and then uses these covariates to predict values for locations that were not sampled. The figure on the bottom shows 6 different covariate layers that could be used in geospatial modeling. The covariates we use in our modeling are publicly available, and they come from sources including university research groups and NASA. So while here we are only showing 6 of the covariates, we use many more in our modeling process. So I'll go through a brief overview of the methods. I won't go into too many of the technical details, but we'll have references for further detail. So the first step here is to integrate the DHS indicator data and the geospatial covariate data. DHS household surveys are collected in groups known as clusters, and the clusters are what is georeferenced. The map on the left shows the GPS coordinates of the clusters sampled for a DHS survey in Zambia. The figures on the right show 4 of the different geospatial covariates that we use. Unlike the cluster level map on the left, for these maps, there are values at all locations within a country. They are gridded data sets divided into 5 by 5 kilometer squares, which are called pixels. There are values at each pixel. We overlay the geospatial covariate data on the indicator data layer and extract the values of each covariate at each cluster. After extracting the covariate data for each cluster, the next step is running 3 different models to generate the predicted outcome of interest. So different models have different strengths and weaknesses. We take an approach where we use 3 different modeling algorithms and then use their different outputs as inputs into the final model. So using the combined indicator and covariate data, we use the 3 modeling algorithms listed here to produce different prediction surfaces. So we use GAM, LASSO, and XGBoost. When running the 3 different modeling algorithms that we use, we see that each algorithm has a slightly different prediction. So rather than rely on a single algorithm, we rely on multiple algorithms. And this approach has been shown to improve the predictive accuracy of the final model. Now that we have our 3 different prediction surfaces, we use these as covariates in a final model to produce the final pixel level estimates. We use a binomial spatial regression model where the outcome, or the number of positives for each binary indicator at each cluster, is modeled as a function of the covariates, which here would be the 3 different submodel prediction surfaces. And we have both a spatially correlated and random error term. This results in the final model output, which is shown on the right. Finally, we need to aggregate this output to the admin 2 level. So while the modeling process gives us a detailed output at a 5 by 5 kilometer resolution, we are interested in aggregating this output to the admin 2 level. To do this, we overlay the model output on the left with the gridded population count data. For each admin 2, we calculate the population weighted average of prevalence within that boundary. This is so the estimates of pixels within an admin 2 that have a high population count are weighted greater than the estimates of pixels with little to no population residing in their location. And this results in the final admin 2 estimates shown here on the right. So we'll now be presenting results from a case study to explain what output we produce through this modeling process and describe how these results can be used by in-country partners. The case study presented today will be the indicator population living in households using an appropriate water treatment method. So for this indicator, the higher the percentage, the better the outcome, while the lower the percentage, the worse the outcome. We'll be presenting the results of this indicator from the 2018 DHS survey conducted in Zambia. So Panel A presents the Admin 1 estimates produced from the DHS. So here we see a range of estimates. We have 2 provinces in that dark red color representing the highest percentage of population using an appropriate water treatment method. And then we have 1 province in the west in that lightest color representing the lowest percentage of the population using an appropriate water treatment method. Panel B presents the modeled Admin 2 estimates. So even on first glance, you can see that there's a lot more variation that's apparent in Panel B than when you just look at the Admin 1 estimates alone. And then finally, we have Panel C, which represents the uncertainty associated with the Admin 2 estimates. So here the metric that is used is the width of the 95% uncertainty interval. So districts with darker colors have greater uncertainty, and districts with the lighter or yellow color have less uncertainty. So in addition to national data, sometimes it's easier to find value in these estimates at a subnational level, and you can see the districts more clearly. So here we'll focus on one particular Admin 1, Central Province. So the map on the right is just the zoomed in version of the selected province on the left. So the subnational results are shown here for Central Province. In Panel A, we have the Admin 2 estimates, and in Panel B, we have the uncertainty. And then in the table below, we have the metrics associated with the figures above. So we have the third column from the left has the estimate, and then we have the lower bound of the uncertainty interval, the upper bound of the uncertainty interval, and then the width, which is just the upper bound minus the lower bound. So I will add note here that another value that we plan to add to these tables is a population metric. So we'd like to quantify how many individuals in an Admin 2 have or are positive for the outcome of interest. So while we currently provide the percentage estimate only, we think it's beneficial for policymakers to know how many people are actually living in a particular district with the condition, as there might be a district with a very high estimate, but perhaps that district is very sparse, and another district with a slightly lower estimate really has many more individuals that need assistance. So both data points, both a percentage estimate and a population metric, we think would be useful to have for planning. So now that we've seen the results, an important question is how can these estimates be used? Here I'll present a few different ways to use these estimates, and then I'll describe some practical examples showing how policymakers and program planners at the national and subnational level can use these estimates. So one approach would be to rank the admin twos. So here you would sort them from the highest estimate to the lowest estimate. And then at the national level, program planners could use this to target resources to the lowest performing admin twos. Additionally, this could inform research topics such as exploring disparities between the highest and lowest performing admin twos and looking into factors that are driving these disparities. Additionally, the admin two estimates could be compared to either the national or admin one estimates. And here, you could target resources to the admin twos that might be falling below the national or admin one average as one example. And then finally, the admin two estimates can be compared over time to monitor subnational progress. So after modeling over multiple surveys, you can start identifying which admin twos are making progress, which might be stagnant, and which might be falling behind. Additionally, we see this as a really important tool for district level program planners. So they have some estimate at the district level rather than just the province in which they reside, and they can monitor that as well. And finally, you can also use this approach to inform research questions and looking to what factors are leading to particular admin twos making improvements and others that are not. So now I'll go through a couple of different scenarios of practical examples. So here the first scenario is at the national level, and this is a water, sanitation, and hygiene, or WASH policymaker, and they're working at the national level, and they've received the admin two estimates for Zambia. They might be interested in understanding which are the districts with the best and worst outcomes. To do this, you would rank the districts by admin two estimate. So on the table on the right, we have the top 10 districts for Zambia. And we can note that they're in 3 different admin one provinces. 2 are in Lusaka province, 1 is in Central province, and 7 are in Copperbelt province. Similarly, when we look at the bottom 10 districts, we note they're also in 3 admin one provinces. 5 are in Western province, 3 are in Southern province, and 2 are in Northern province. So an important question is, how do the admin two estimates add nuance to the interpretation of the admin one estimates? So in the map on the left, we have the admin one estimates, and the map on the right, we have the admin two estimates. So just looking at the admin one estimates alone, we note that the top 3 admin one provinces are Lusaka, Copperbelt, and Central. When looking at the top 10 districts that we showed in the previous slide, they're also in the same 3 admin one provinces. Although one area to note is that the second performing district overall was actually in Central province. When you look at the admin one map, Central province is the 3rd highest province. But the disparity is more clear when you're looking at the bottom 10 districts and bottom 3 provinces here. So from the admin one estimates alone, the bottom 3 admin ones are in Western, Southern, and Eastern province. But the bottom 10 districts were in Western, Southern, and Northern province. So one might want to know why this is. So let's look at Northern province and see what's going on. So in the admin one estimates on the left, Northern province has an estimate of 25%, and it's the 5th out of the 10 provinces overall. So it's kind of middle of the pack. So you wouldn't really think that this particular province might need additional resources. But when you look at the district level map, you can see why this is. So there are 4 districts with that lowest estimate, and then there's 1 district in that darker orange representing a higher estimate. So that essentially the darker orange district is pulling up the average overall. So even though this province has 2 of the worst performing districts nationally, because it also has a district that's very high performing, those districts wouldn't be apparent from the admin one maps, that particular area might need additional resources. So I'll go through a second subnational example, and here we have a water, sanitation, and hygiene policymaker again, and they're working in Central province, which is the province that I showed results from in the previous slides. So similarly, they might be interested in understanding which district is the best performing. And here they can see after ranking the districts that would be Kabwe, which is that dark red district in the center of Central province. Additionally, they might be interested in understanding which district might need additional intervention. And here that district would be Mumbwa, which is that lighter shaded in that lighter yellow color on the western side of Central Province. So additionally, a policymaker here might be interested in understanding what factors are driving the differences in outcomes between the districts in Central Province, as clearly there's a wide range of estimates, even though they're within the same province. So you have estimates varying from 22 to 61%, and then 4 of the districts are between those two extremes. So the DHS program has developed a plan to routinely model Admin 2 estimates for surveys. We have developed a proposed list of 18 indicators to start routinely modeling. The indicators represent the range of demographic and health topics that the DHS surveys cover. So we have variables on nutrition, child health, family planning, reproductive health, education, malaria, water and sanitation, domestic violence, childhood mortality, HIV, and HIV/AIDS. So I will note here that while these indicators have been selected because they represent a range of topics and are thought to be useful topics to have for subnational monitoring over time, this list may be refined during conversations with partners. Additionally, we plan to have conversations with countries during the survey planning process where we will discuss the feasibility of any additional indicator requests. So this list may be refined or expanded depending on a country's particular interest in the subnational estimates. So in addition to this list, we've also developed a process to start routinely modeling the indicators. We've developed a proposed budget, data requirements, and timeline. And finally, we plan to start piloting this process on upcoming DHS surveys. So we're really interested in getting feedback from partners and then refining the process as needed. So for more detail on the methodology used in this approach, you can see Spatial Analysis Report 17 or SAR 17, which is shown on the left, and that's on the publications page of the DHS program website. And then for more detail on how country partners can use these Admin 2 estimates, you can see Spatial Analysis Report 20, which is designed for non-technical users to use these Admin 2 estimates in practice. And so with that, thank you for your attention.
Great, thank you, Rose. So now we are going to turn things over to Dr. Sara Riese. Sara, take it away.
Great, thank you so much. Okay. All right, so good morning, good afternoon, and good evening to all of those joining. So I'm going to be presenting our recent methodological report on measurement approaches for effective coverage estimation, which was co-authored with Shireen Asaf and Tom Pullum. So we integrated data from 2 different sources, so household surveys, specifically the DHS surveys, and health facility data, so specifically the service provision assessments or SPAs, which are also implemented by the DHS program. Now, to start us off, I just wanted to get a sense of kind of the audience's experience, with effective coverage and the concept, which is really the basis of this presentation. So, Chris, could you bring up the poll? And I just wanted to ask if the participants could just tell me quickly, kind of what is your experience with effective coverage? And I'll just give everybody a few seconds to do this. Okay, great. So we have about 2/3 of folks have participated. So I think we can, let's give everybody just another second. All right, Chris, can you close the poll and we'll share the results? Okay, so we can see that, it looks like, most people have actually never heard of or used measures of effective coverage. About the same number have kind of heard of effective coverage, but haven't really applied it in their work. And about 16% have used effective coverage measures in their work, which is kind of very useful for me to kind of benchmark. Okay. So I think this will be hopefully helpful then to kind of just quickly go over kind of what is effective coverage and why would it be a valuable measure. So for a long time, research has been very focused on coverage measures. So coverage, looks at the population of people who need a service or an intervention and asks, well, are those people accessing the services they need? So for example, what proportion of pregnant women have any antenatal care? What proportion of sick children go to a health facility when they're sick? And so the dark blue bars on this slide kind of illustrate some of those coverage measures. Now, while coverage, does provide valuable information, it only provides kind of one part of the overall picture. And researchers found that coverage levels weren't always associated with better health outcomes. So this led to a shift in focus to look at quality. So both the readiness aspect of quality, so whether or not facilities are ready to provide necessary services, as well as the process aspect of quality. So whether clients who visit facilities, receive care that's really up to standard. So instead of just looking at whether or not people are going to a facility, we want to know whether facilities are ready to receive those clients and to provide the services. We want to know, what's happening when they get there. So are the pregnant women who are coming to antenatal care at a facility, are they receiving all of the recommended antenatal interventions? Now, the dark blue bars on this slide kind of illustrate these readiness and process quality measures. So this is better, but still only really looks at one specific piece of service delivery. Neither coverage nor quality really gets at the full picture. Now, effective coverage then puts all of these different pieces together for a more holistic picture of what is happening with a service in a country or in a population. So this image shows the effective coverage cascade, where we start with the population who need a service and stepwise kind of build upon that. And at each step, we're effectively adjusting for different aspects of service delivery, for different measures of coverage, different measures of quality. And quality adjusted coverage, which is at the far right on this slide, is the product of all of these different measures. And that has been found to be more associated with outcomes than simple coverage measures. Okay, so this sounds great. So why aren't we all using effective coverage as a common measure? Well, as you may have seen, you saw in that poll, many programs and researchers are increasingly talking about or using measures of effective coverage to describe their programs or health systems, or to compare them with others. However, there are some challenges to this. So, first, some of the data aren't always available. So, not all countries have DHS data, as we saw in that slide in Rose's presentation. And while many of the DHS measures may be available in some HMIS systems, health facility data may not be available in an HMIS. And only a few countries have done a service provision assessment or have other health facility assessment data widely available. Now, second, different data sources may collect different pieces of data, and there are no standard definitions of service readiness or process quality, even within clinical areas. So this is an issue if you're trying to compare effective coverage over time or between two different areas, geographic areas. They may be using different definitions of quality. So if different countries are using different data sources with different definitions of quality, those estimates of effective coverage may differ in ways that shouldn't necessarily be directly compared. Now, third, there are different approaches to linking individuals with facilities. So if the data are available, we can use direct linking approaches to identify the specific provider and facility that an individual visited. And alternatively, we could use an indirect or an ecological linking approach that aggregates findings from households and individuals within a geographic area to providers and facilities in that same geographic area, which can be a cluster or a district or a region. Which approach you choose often just depends on what kind of data you have. Now, finally, when the estimates are created, the methodology for construction of confidence intervals around estimates of effective coverage has been unclear. So this means that when comparing different estimates of effective coverage, two estimates that may look different may not actually be statistically different from each other. And this is primarily an issue when you're combining and integrating your DHS and SPA data. So in this paper, we sought to compare a few different approaches to calculating effective coverage estimates to allow us to really better understand the implications of each approach. So we looked at two service areas, antenatal care and sick child care, and we looked at 5 countries that had a DHS and a SPA survey within 2 years of each other. So we used 3 measurement approaches. One used DHS data only. One combined DHS and SPA data and used basic service readiness and process quality measures from the SPA. And the third combined DHS and SPA data again, but used expanded service readiness and process quality measures. And with all of the different measurement approaches, we used an indirect linking approach with aggregate national measures of coverage and quality. So what does this look like in terms of data? So here we'll just walk through an example. So this table shows the input measures and calculations for the steps in the effective coverage cascade for approach 1, which uses only DHS data, and for antenatal care. So the input measures are shown across the top, and the steps in the cascade are along the left side. So the first step in the cascade is service contact coverage, which in antenatal care is measured as women with at least 1 antenatal care visit with a skilled provider. Now, normally, the next step in the cascade would be input adjusted coverage. But since in approach 1, we're using only DHS data, we don't have any facility readiness data, so it's not applicable. For the next step in the cascade, intervention adjusted coverage, we use the receipt of complete intervention measure, which is receipt of at least 4 antenatal care visits. So while the current WHO recommendation is 8 or more visits, since the time period for most of these surveys was prior to 2016, we used the earlier recommendation of 4+ visits. And so in order to calculate intervention adjusted coverage, we multiply the coverage measure by the receipt of complete intervention measure. Now, for the final step in this cascade, we look at the process quality of care received. So in the DHS, women are asked about the content of their antenatal care visits. So did they get their blood pressure measured? Did they receive iron folic acid tablets? Did they receive a tetanus vaccination, et cetera? And so we used this information from maternal report to calculate process quality. And so the quality adjusted coverage for approach 1 is then the product of these 3 measures that we have in the DHS. Now for approach 2, which combines DHS and SPA data, we have a similar table, but with more data. More of the cells are filled in. So you can see in the second column, since we are using SPA data, we now have this facility readiness data. So to calculate input adjusted coverage, we multiply that same DHS coverage measure with this facility readiness measure. Now for quality adjusted coverage, the measure of process quality in the far bottom right cell changes with the inclusion of the SPA data. So instead of using maternal report of care received during antenatal care, we now use observation data from the SPA to assess the quality of care provided during those antenatal care visits. Now, you may be wondering how we selected items for readiness and process quality. Now, the basic measures of facility readiness and quality of care were created for antenatal care and sick child care based on previous DHS research to identify a quality of care index. Now, for approach 3, which again combines DHS and SPA data, this table would stay exactly the same, but where you see the word basic in red, you would replace it with the word expanded. So there were, the measures of readiness and process quality had a more comprehensive list of items. And for approach 3, these items were selected based on a literature review of global antenatal care and IMCI standards, as well as previous research into measures into antenatal care and sick child quality of care using SPA data. So let's turn to the results. So this table shows the results for the specific measures we use to calculate the effective coverage cascades. So to present the results, I'm really just going to focus on Haiti and Malawi in the interest of time. But if you're interested in the results for the other 3 countries, you can refer to the report. So we can see that overall antenatal care coverage in Haiti and Malawi is high. So it's over 90% for both. While for sick child coverage is low, so only 26% in Haiti and 53% in Malawi. Now, there are a few other things to notice here. First is the readiness measures. So you can see that in Haiti, for both antenatal care and sick child care, the basic readiness measure is higher than the expanded, while in Malawi, in antenatal care, the expanded measure is higher than the basic measure. Second, for receipt of complete intervention in sick child care, you can see that approach 1 is much lower than the other 2 approaches. Now, this is because this measure, which identifies children with diarrhea or acute respiratory infections in the last 2 weeks who received appropriate treatment, is slightly different in approach 1 versus approaches 2 and 3. So in approach 1, which uses DHS data, the actual diagnosis of the child is unknown. And so any child who had symptoms of diarrhea or ARI are included in the denominator. Now in the SPA, so in approaches 2 and 3, data collectors observe whether children brought in with symptoms of diarrhea or ARI were in fact diagnosed with these illnesses, and only those, who received a diagnosis are included in the denominator. Now, finally, for process quality, we see that the process quality measure using DHS data alone in approach 1 have consistently provides larger estimates compared to using SPA data. So this reflects previous research that shows that maternal recall of common actions within antenatal care do overestimate the quality of care. All right, so now let's look at the actual overall effective coverage cascades. So here are the antenatal cascades for Haiti and Malawi. So you can see that in both cases, the quality adjusted coverage measure, which is the darkest blue bar, is higher in approach 1 when we use DHS data only, while approaches 2 and 3 have relatively similar estimates. For approaches 2 and 3 in this antenatal care example, one thing to note is that there's a pretty steep drop off between the crude coverage measure, so that first gray bar, and then the input adjusted coverage, that lavender bar, which accounts for facility readiness to provide the service. Now for sick child care, we can see that the crude coverage starts off much lower than antenatal care in both countries, as we noted earlier. Now for sick child care, we don't have any process quality measures in the DHS. So for approach 1, we can only go out as far as intervention adjusted coverage in the cascade. And if we compare intervention adjusted coverage across the different approaches, approach 1 is not markedly higher, as we saw with antenatal care. In fact, it is lower than approaches 2 and 3. So this is actually due to that different measures, different denominators use of that receipt of complete intervention measure that I mentioned earlier. Now, in both countries, there is a steep drop-off from intervention-adjusted coverage to quality-adjusted coverage, indicating that the process quality of sick child's care is poor, no matter if it is measured with a basic or an expanded measure. You can more easily see this in Malawi, where the bars are a bit bigger, where the coverage started off higher. And it's more difficult to observe in Haiti, where the cascade starts off so low that the bars are very small over the entire cascade. So we had a few hypotheses going into this. First, we thought that for antenatal care, quality-adjusted coverage would be higher in approach 1 than for approaches 2 and 3. And this did prove to be the case, primarily due to the issues with maternal recall that I discussed earlier. Second, we thought that for sick child care, intervention-adjusted coverage would be lower or similar using approach 1 compared to approaches 2 or 3. So this was also the case, due to the differences in the definition of sick child complete intervention using the DHS versus the SPA data. The third, we had thought that the expanded readiness and quality measures used in approach 3 would result in lower or similar measures than the basic measures for both antenatal care and sick child's care. However, this was not consistently the case across countries and service areas. Now, finally, from previous work, we thought that sick child care quality adjusted coverage would be lower than in antenatal care, and this was found to be the case. Now, the main reason here is that we know that from previous research, sick child coverage starts out much lower than antenatal care coverage. And when your first measure in the cascade is already very low, when it's multiplied by other measures, it's just going to end up lower. So even if the subsequent measures are high, it's just difficult to catch up to that initial low figure. So what are the key takeaways from this research? So I think, first that, incorporating those health facility measures of readiness and process quality do provide better effective coverage estimates compared to using only DHS data. So, the integration of those two sources of data is really worth it. And second, that those simpler, shorter measures of service readiness and process quality provide very similar estimates of effective coverage, compared to the expanded measures. So in this case, more items does not necessarily mean a better measure. That's all I have for you today. But if you're interested in the findings for the other 3 countries or more information about the confidence interval estimation, or just want to know more about the research in general, you can visit the MR31 report page on the DHS website. And thank you very much for your attention.
Great, thank you, Sarah. So now we have time for questions, discussion. I know there's a number of questions in the Q&A. I don't know if Rose, if you would like to go ahead and start with the review related to yours.
Yep, I'll get started. Okay, so the first question is, there are a few questions on the uncertainty intervals and explaining them and how they were being used. So I had a slide on that and we ended up taking it out for time purposes, but I'll go through that now. So just to start with, all statistical or modeled estimates have a degree of uncertainty associated with them because we're not actually asking every single person living within that district. So uncertainty isn't unusual. But essentially an uncertainty interval just indicates that while we don't know for certain what the actual estimate, the actual value of the indicator is, we're highly confident that the actual prevalence is within the lower and upper bounds of the uncertainty intervals displayed. So that's why we show both the lower bound, the upper bound, and then the width is just that we have a single metric that we can put on a map. So essentially, the larger the uncertainty interval indicates larger uncertainty about the indicator estimate, while a smaller uncertainty interval indicates we are more certain about the indicator estimate. So it's definitely good to keep in mind. And we have a little bit, and if you want more detail on that in SAR 20, we go into uncertainty intervals in more detail. And I think that link was in the chat, but I can add it again if not. Okay. Another question wanted to know, can you share the 18 indicators that you plan to routinely model at the admin 2 level? Will this be done for all countries? Also, what are the implications for countries that do sample at the admin 2 level? So the 18 indicators were in the presentation, so you should be able to refer back to that. And they're also in SAR 20 again on page 19 is the table that we're proposing. So again, these 18 indicators aren't finalized. This will likely be slightly variable for countries, and we're not guaranteeing that these 18 indicators will be modeled for all DHS surveys. But this is kind of what we're thinking right now. And yes, there are a select number of countries that sample so they can obtain key indicators at the admin 2 level, but this isn't the norm. And usually even for those surveys, they aren't able to estimate all indicators at the admin 2 level. So for those particular surveys, we'd likely discuss with the country if they'd like to model different indicators, which were not sampled enough to provide the admin 2 estimates. Okay, let me take one more and then I'll see if Sarah wants to jump in with a few. There is one question on the covariates and asking if covariates would get updated or added if more or better data becomes available. And then they also wanted to know, would DHS update the predicted level 2 estimates? So currently we use the covariate for the year closest to the survey year. So our thinking now is that if a particular covariate gets replaced with improved data, I don't think we're planning to regularly update the model output. We'd probably internally test the updated covariates out on a few indicators to review whether the model output was significantly impacted. But given the number of covariates we use, as well as even updated covariates likely shouldn't dramatically impact the patterns, we don't anticipate that this would significantly impact the model output. But it's something we'll definitely monitor and evaluate if that's necessary. Sarah, do you want to jump in on a couple, or do you want me to keep?
Sure. No, I can jump in. Great. So I think the first question that I saw related to my presentation was about how to control for confounders when estimating coverage, especially variables related to socioeconomic status. And so, I think this particular work was really just trying to do those aggregate national level estimates and really just comparing those approaches. And I think, if you want some future work that we're going to be doing is going to be looking at kind of equity in effective coverage estimates. One challenge that we have is that in the health facility data, we don't have socioeconomic status on clients. So we only have that from the DHS. And so you can only kind of incorporate that at the level of the DHS. But if you do have that data available at a client level in your health facility, then you could disaggregate the quality by client socioeconomic status, and then calculate that kind of effective coverage cascade for lower or higher socioeconomic status. So you could do something like that if you have the available data. And then there was another question about the criteria for selecting the approach. So this person was asking, for example, if they wanted to see kind of access of care for women with IPV, which approach would serve better. And I do think that, it really depends on what data that you have. So I think one of the key takeaways that we had from this is that incorporating aspects of health facility data does really help kind of provide some nuance to the effective coverage estimates. So if there are if you do have available data at the health facilities, I think that would be valuable to incorporate if you have it. But if you don't, you work with what you have, understanding kind of what the implications of that would be. So if you only have household survey data or interviews with women, you can use that, but just understand kind of what the limitations would be. And then I'll just take maybe one more, and then I'll toss it back to you, Rose, for a couple. So there's a question about what's the lowest level cluster, region, or district for which the integration of DHS and health facility data is valid and representative. So generally, the DHS data are representative, at a regional level. Although during Rose's presentation, I started thinking about how we could incorporate, the work that she is doing in, the work with that we're doing on effective coverage. So maybe there's a future integration webinar there. But so generally, this would be valid kind of at a regional level. You could have regional estimates of, coverage, and then regional estimates of quality, and, calculate effective coverage estimates at the regional level. Rose?
Yeah, great. So there's one question on, are the indicators selected primarily because they tend to be fairly high coverage or prevalence? So right now we selected the indicators primarily. We selected a few from each of the different subject areas that DHS surveys cover. So most of these have been modeled. There's a few that we still need to test it out, which is another reason why those list of 18 isn't final, but they were generally selected because most of them were able to be modeled, and they represent the range of topics that we cover. So we wanted a few different indicators from each topic, so they would have some representation with the idea of being modeled over multiple surveys. Let's see. There's a question on whether we're planning to publish the R scripts and ArcGIS layers onto the DHS GitHub for open science and reproduction purposes. We are trying to go that route. It's not the code isn't really ready right now to do that, as it's just pretty complex. So we're trying to, that's one of our goals in the future though, is to actually publish it and have it so people can go through it and reproduce. So we just need to add some more comments and descriptions into it. We are planning the actual map. We are hoping to have some visualization tool on the website to actually visualize the Admin 2 estimates, because we think this will be easier in some ways than having a static Admin 2 map, so you can actually zoom in or focus on a particular province. So that is in the works. Let's see. There's another question on, are there PII exposure risk if we go to Admin 3? So I guess two things on this. First, the DHS geospatial data is displaced. So the rural clusters are displaced up to 5 kilometers, with 1% being displaced up to 10 kilometers. And then the urban clusters are displaced up to 2 kilometers. So just to note that, that's one way we already control for exposure risk. For Admin 3, that's a good question, but I guess right now we're not planning to model at the Admin 3 level. So I think that's something that if we were interested in going farther, we would have to address. But right now we're planning to just model at the Admin 2 level. Let's see.
I see one more question
Go
for me,
it.
so I'll jump in on this.
Yep.
So somebody was asking if the effective coverage methodology requires to have kind of DHS and SPA surveys done during the same time period. And generally, we recommend that they have happened within 2 years of each other, because you want to have, those indicators measured, within generally a similar time period, as we know that, coverage and quality kind of these are, can fluctuate. So within 2 years is kind of the maximum difference that you want to have between, the DHS having been done and a SPA survey having been done, or, health facility assessment having been done.
Great. I have one other question that came up. So if groups external to DHS have developed infrastructure approaches and code to estimating pixel and Admin 2 estimates for the 18 priority indicators, Will you plan to work with them to not duplicate efforts, especially since they use DHS data as key model inputs? So I would say we are open to collaboration with any groups. I think one thing to note is that our goal is to start routinely producing them. So when each DHS survey comes out at the same time, we'll be able to also release the admin 2 estimates to increase visualization or to increase the focus on them, because generally a survey release is when there's a lot of attention being given to them. So I think we'd be open to that, but we also want to do this routinely. So it's something that people expect from a survey. And I will note that we are also working with other groups like IHME and University of Washington already. So there is we're not working in a silo. There is collaboration ongoing as well. But for the groups that we're not working with, we would definitely be open to working with them as well. Let's see, there's one other question on, is reporting admin level 2 worthwhile if a country has a population of less than 10,000? We have small countries in the Caribbean. I think that in general, it's nice to have lower level estimates because I guess we're living in a resource constrained environment, and being able to prioritize particular areas for additional intervention would be helpful. So I think that's something that we'll also be finding out when we pilot this with different countries and get feedback. But I think there's been a lot of interest, so we're hoping that these estimates will be really useful for policymakers.
We've got about 1 minute left if you want to take 1 or 2 more questions, and then we can wrap it up.
I see there's a comment in the chat about equity adjusted effective coverage, and that is actually something that we're exploring, working on this year, is looking at equity and effective coverage across regions and socioeconomic status as with the limitations that we have, that it's only available in the DHS data right now. But that is something that we're working on this year to kind of move this work forward. So look for an additional report on that in later this year.
Great, thanks, Sarah. Well, thank you both. Let's go ahead and wrap up here. We just hit the 10 o'clock hour Eastern. Thanks everyone for joining us today. The slides and the presentation will be sent out to everyone afterwards, and you'll also be able to get access to things on the Data for Impact website. And please keep an eye out for upcoming webinars in the series. Have a good rest of your day.